you all know that immunosuppressive drugs may cause a problem in your kidney. And this is really something that we should not forget. And we can discuss some of these items later on. So what is important? We have the issue of rejection and side effects of immunosuppressive. We have the general health issues. So to me, it's very, very important that if there is an indication that patients should take a statin, liver transplant recipients receiving immunosuppressive drugs does not prevent you from being candidates for aspirin, for anticoagulative drugs, for statins, and to really take care that your diabetes is well controlled. This is becoming more and more important in the long term after transplantation. And I touched on the risk of infections and cancer. We may discuss screening algorithms. So I have prepared some slides, but we can discuss it. But what is very important, all these issues should not be seen independently. They all interact. So obviously the immunosuppression influences your risk for infections and your cancer risk. And they may, on the other hand, if I have to take a statin because I have cardiovascular disease, then obviously my statin may influence my immunosuppression. And this is the point that care of liver transplant recipients is not only, let's say, a one physician, one doctor show. We need to work together on all different levels with our colleagues in different disciplines to really achieve this goal, which I mentioned in the beginning, that we have this long-term survivors, that we have wonderful examples, and that we're not talking about 5-10 years, that we're talking about 3 decades survival after liver transplantation. This is our main important point. And in the end, there is, for each of you listening to this one, there is no one-size-fits-all answer to all your questions. And I think this is probably the most important point I want to highlight. Even if one patient is requiring a slightly higher immunosuppression, is requiring 2 or maybe even 3 drugs to prevent rejection, this may not be the case for other patients. You all know that in some settings, even complete weaning of immunosuppressive drugs after liver transplantation is possible. And this is unique in organ transplantation. I think this is really spectacular. This is not possible after kidney transplantation. This is not possible after heart or lung transplantation, but after liver transplantation in the long term, in a proportion. Yes, it's a small proportion of individuals, but weaning of immunosuppression is possible. And I think this is, in my view, really one issue that again highlights how special the liver is in this context. And I discussed this several times. Obviously, the higher the risk, the higher level of immunosuppression, the higher risk is you have for infections, renal impairment, cancer, diabetes, cardiovascular risk. The fortunate thing is that we live in the year 2024, and Teresa and Speranza, when we started transplant hepatology a longer time ago, it was much more complicated. Now we all have these apps that can really help us making our life much easier. Therefore, let's say the concern of drug-drug interactions, which antibiotic may interfere with microchronimus, and so on. The life is much easier. But I think each patient should be also aware of this one. Sometimes you may forget that interactions may appear, and therefore we all should keep this in mind, but we are all using apps, and patients may also check some of these interactions if they are uncertain. And now I have a question also then to Teresa and Speranza. Immunosuppression, I think it's quite clear, less, maybe more, not always, in frequent cases. So what we are running here at Hanover Medical School, we are running protocol liver biopsies to detect subclinical rejection. So we biopsy patients after liver transplantation, even if they have completely normal liver enzymes, to detect this either low level of rejections, or also to be really sure, if we want to reduce our immunosuppression, that there is no subclinical rejection ongoing. And that's something that I think is working quite well. I don't know, Esperanta, in Romania, are you doing regular liver biopsies or not?
I wish I would do, but not. The patients are not so open to this. And I must admit that, in my opinion, it's the best strategy to follow, but it's a little bit difficult to convince all of them to do this. Still, we have some patients, at least one, that I really know that he stopped immunosuppression by himself, and then we convince him to follow him with liver biopsies. So it's well already for more than 4 months since he stopped, and it's everything okay, also in the liver, the histology level. And regarding the immunosuppression and apps, I must admit that it's quite easier for us. But what I find difficult is that a lot of transplanted patients want to take a lot of herbs or some non-medical, I don't know, just supplements or something that are not really in these apps. And sometimes it's difficult to convince them not to take them. And there are also new drugs, very new drugs that we cannot find in these apps. So there are still challenges also for us.
Teresa?
Yeah, we also perform liver transplantation protocol because not for rejection, because you can find it, but it's important to decrease the immunosuppression because of the complication that you told before, cancer, cardiovascular events, and so on. So when I suggest to my patient to make liver biopsy, and I think that I must have 4 or 5 patients who are very afraid by biopsy, but all the rest I succeed in making liver transplantation to them, because this allows me to personalize the immunosuppression. And today it's very important because we have learned the lessons of the past, in which we have 30-40% of patients in dialysis. When I started, we had 30% of patients in dialysis. So that's why I think that's very important to make less is more.